Hi everyone, welcome to this episode of the REFERROLOGY series. Today we're talking about seizures and epilepsy. We are very fortunate to have Dr. Rahul, who's a neurologist who specializes in seizure and epilepsy. And today I have Hazel with me, who will be asking and going through the questions that we have. So maybe we can start with a short case scenario. So Mr. K is a 25-year-old who comes in with loss of consciousness. So he was basically just out in the park and was found lying unconscious. Um, so when he came in, the history from the SCDF was that he had lost consciousness for about 5 minutes, was found to be lethargic and confused, and eyewitnesses apparently noted some jerking movements, but they were not really contactable for further history. So he came in, his blood sugar level was normal, a CT brain was performed, an EDM was reported to be normal, and he was admitted to the ward for a presumed first onset seizure. So maybe Hazel can kick us off with the first sets of questions.
Yeah, so I think on call, a lot of times we see a lot of admissions for loss of consciousness. So we do have to take a history and examination to kind of differentiate the causes of loss of consciousness. Just wanted to know if there are any sensitive and specific aspects of the history that can point towards seizures.
Yeah, I mean, obviously, the most ideal situation is if you're able to get an eyewitness account of the event. Nowadays, also, we have found it quite useful. You might not be able to get it straight away, but sometimes people are able to obtain CCTV recording. If it happens at work or at a shop or a mall, and that gives us really a lot of information. From a history point of view, assuming that you don't have an eyewitness account, then you don't have much to go on. It's useful to divide the history taking into 3 phases if you're taking it from the patient. The first is the pre-ictal phase. So often some patients are able to tell you that they felt funny or they felt that something was off before they actually lost consciousness. And very often that history can help us to decide whether this was a epileptic seizure or another cause of loss of consciousness. For us, the biggest second differential would be whether this is something like a syncopal event or a convulsive syncope. So if patients describe a prodrome where they describe, tunneling of vision, they started to feel cold or sweaty and not well just prior to losing consciousness, then that would be consistent with somebody who's having a syncopal episode. If somebody gives you a history that's more suggestive of an aura, so an aura is kind of the premonition or a pre-ictal phenomenon, and that varies depending on which part of the brain the seizure originates from. The most common aura that all of us know about is the temporal lobe type of aura. So these phenomena such as deja vu, jamais vu, some even describe a funny taste in their mouths or very funny smell. So these would be unusual for syncope. These are more specific and more focal descriptions of an aura. Then, of course, if you can have an eyewitness account, you want to know whether there was some subtle movements before the seizure, whether the patient appeared to go blank for an extended period of time, and whether the patient was able to tell somebody that something was going to happen. Then you have the actual ictal event, and that one really, ideally, you would get an eyewitness account, such as dystonic posturing of one limb or both limbs, or tonic-clonic type of seizure. Was there foaming at the mouth? Was there biting of the tongue? Was there blood coming out of the mouth? These would help you to try and decipher the nature of the event. Failing which, most patients, if they're having a tonic-clonic type of seizure, won't be able to tell you what happened during the seizure. Most of them don't have any awareness. Then you're left with the final phase, which is the post-ictal phase, and we find that actually very useful. Most epileptic seizures, which culminate in a convulsive episode, will have a post-ictal phase, and the duration of the phase may vary from one patient to the next, but it's usually actually several minutes, if not longer. So often we ask patients when they came around, when they regained consciousness, where were they? And some patients say the next thing I remember when I woke up, I was already in emergency department.
Okay.
So that implies that there's a very prolonged post-ictal amnesic phase of at least 10, 20 minutes, if not longer, by the time the ambulance arrives and is able to take the patient to a hospital. And that almost effectively rules out syncope being a differential because of the prolonged amnesic state.
Yep.
Whereas if a patient tells you, oh, I regained consciousness, I was still on the floor, people were around me, and I knew exactly where I was, I knew what had happened, and there was no confusion at all, and the recovery was full and immediate after the event, then that would be more consistent with syncope.
Okay. Got it.
And of course, we can ask the same things about tongue biting. So we find that tongue biting is a fairly good discriminator. So if you see a patient for an unwitnessed episode of loss of consciousness and there is a lateral tongue bite, then you would be highly suspicious of this being an epileptic seizure.
Thanks, Dr. Rahul. What about urinary and bowel incontinence? Is that something that we see, and is it specific for seizure activity?
No, I mean, of course, it's good to ask, but really, it's not been shown to be a particularly useful discriminator
Okay.
because people with loss of consciousness for any other cause may also lose continence. So the
Okay.
presence or absence of incontinence is not terribly useful.
Okay. Got it. Thank you. And maybe before I move on to the next question, in terms of physical examination, is there anything in particular that you find helpful, apart from maybe looking for tongue bite marks, that may help to distinguish a seizure?
Again, you want to assess to see what kind of injury the patient has had. So tongue bite is
Yep.
one. Patients present with shoulder dislocation, for example,
Okay.
that is not related to trauma, that is also a bit suspicious
Mm.
for an epileptic event. These are the things that you would look out for.
Okay. Cool. So just a bit more on history. What are common and important triggers that we should be assessing for when we take a history pertaining to seizures?
Your main goal here would be to try and decipher if you're happy that this was a seizure,
Yep.
whether this was a provoked or unprovoked seizure, and whether this is occurring in somebody who's already been diagnosed with epilepsy.
Yep.
So, assuming that this patient has not been diagnosed before and this is the first ever episode, then common triggers for an epileptic event sometimes are related to sleep deprivation. That's a common one that we see. The other scenario would be, for example, somebody who misuses or abuses alcohol and then suddenly stops consuming alcohol, then those are alcohol withdrawal seizures. Similarly, for benzodiazepine withdrawal seizures. So, again, you want to take a proper drug history along with the rest of your history taking.
Yep.
Some patients also describe intercurrent illness. So basically, any febrile illness, URTI, or anything like that can lower seizure threshold in somebody who is susceptible to having epileptic seizures. So those are things that you would ask
Okay.
about,
Okay.
and any concomitant new medication.
All right. What about
Mm.
the like flashing lights and things like that? Is that common, or is it just more like
Yeah.
described?
Okay. So we talk about flashing lights a lot. So
Yep.
photosensitive epilepsies are relatively less common. They're mainly
Okay.
seen in the pediatric epilepsy syndromes,
I
such
see.
as juvenile myoclonic epilepsy. So those are more photosensitive.
Mm.
In adults presenting for the first time, those kind of epilepsy syndromes would be less common. So you wouldn't expect to get a lot of photosensitive kind of flavor from the history, but it's worth asking.
Okay. Cool. Thank you.
Okay, so for blood test investigations wise, we're just wondering whether there could be anything that could differentiate seizures from other causes of loss of consciousness, like maybe the CK will be raised.
Yeah, so there's been a lot of debate for many years now about the use of blood tests. You've put prolactin up there first, so we can talk about prolactin.
Okay.
So there was some initial excitement that prolactin would be a very useful biomarker to differentiate between sort of epileptic seizure or a non-epileptic event. But really, the data now points a little bit away from that. It still can be useful, but you have to appreciate that there are quite a few caveats before you use prolactin reliably. First is that the prolactin has to be taken fairly early after the event. So the peak sensitivity is less than 20 minutes after this actual event has occurred. Um, so that, from a practical point of view, is usually very difficult. By the time the patient comes to hospital. So if this is a ward patient who has a seizure, then that is a slightly different scenario. Second is that prolactin will help you to differentiate between a convulsive seizure or a complex partial seizure versus a non-epileptic attack, or what we previously used to call a psychogenic seizure. But it's not been shown to be useful to discriminate between a seizure and syncope. So those are the caveats associated with prolactin. And of course, normal prolactin does not exclude seizure as an event. Okay, so you have to have a high pretest probability before you decide what to do with the prolactin result. Next, you talked about CK. So again, the CK, there's some caveats. So CK is a non-specific test. It just indicates it's a muscle enzyme. So anything that causes raised CK, such as exercise, somebody's gone to the gym, any intramuscular injections or fall, those will result in a raised CK. So in itself, it's not particularly useful. Other people have used lactate. So again, somebody who's coming in with a convulsive seizure and you're able to get a very high lactate after the event, again, you should be a bit suspicious of this having been a seizure. But the reverse is not true. So normal lactate, again, does not exclude seizure. So until now, we really haven't found a very useful serum biomarker for epilepsy.
Okay. Just an interesting thing that I've observed. I've noticed that in quite many patients who come in with seizure activity, the total whites can also transiently be elevated. Is that something that you see commonly as well? And
yeah. So you can get a raised total white count, which is not uncommon.
Yep. But once again, it's not very sensitive or specific, lah.
No, it's not. In fact, sometimes it's almost a knee-jerk reaction that somebody who comes in with seizure, raised total white count, it's assumed to be infection, and then they start antibiotics.
Yep, exactly. Okay, thank you very much. So I think the next question is something very relevant for the people on the ground, because I'm sure neurology gets lots of referrals for, or rather calls to get an EEG expedited for. So we have a couple of questions. So the first would be, what are the indications to perform an EEG? Maybe we can look at it from maybe first suspected seizure, or let's say someone who is known to have epilepsy.
Okay. So for somebody who presents for the first time with an unprovoked seizure, I would request an EEG in those patients because it may help localize where the epileptiform abnormality is, number one. Number two, there are some patterns on the EEG that we can elicit which may help us to identify a specific epilepsy syndrome. And that is useful because then it helps to guide our management. So an example would be a young patient who presents for the first seizure. You do the EEG and you see a specific pattern that may suggest something like juvenile myoclonic epilepsy. Now that helps us because we know that certain narrow spectrum anti-epileptic drugs should not be used in these patients because that can worsen the seizure. And if the pattern is very specific, we really don't even have to do neuroimaging because almost 100% of the time the scans will be normal. So it may be able to save you unnecessary investigation. So that's where I think the EEG would be useful. Scenarios where EEG would not be particularly helpful, in my opinion, is in somebody who's already been diagnosed with epilepsy and you have had a previous EEG that has given you some result. Then the patient comes in with a breakthrough seizure and is now back to normal. So that's an important caveat. That means back to his previous neurological state. Then you have to ask yourself whether repeating an EEG is going to give you additional information. And the answer is probably not. It's not going to change your management a lot. However, if the previous EEGs have been normal, then it may be worth repeating it to see whether you can pick up an abnormality this time. So that's something you want to consider.
Okay.
Or certainly if the patient is not back to his neurological baseline, then you would want to do an EEG to make sure he's not having non-convulsive seizures.
Yep. Okay. Thank you very much. So the next question is the time window of when an EEG should be performed. And I think especially over the weekend, this is a bit of a challenge because the patient comes in on Friday nights and then, it's the weekend and it's difficult to get an EEG. So practically, what's your advice on this?
Yeah, I mean, so we know that the EEGs are more sensitive the sooner after the seizure that you do it.
Yep.
Um, so that has the highest sensitivity to pick up integral abnormalities. Of course, you're right. So there are some limitations to resolve. So if the patient is an inpatient, then you just do it at the next available slot.
Okay.
I think if there's some concern that the patient has not returned to baseline
Yep.
and non-convulsive seizures are a possibility, then one would refer to the neurologist on call who can
Okay.
then assess the patient, and if he feels there is a need, may then be able to trigger a kind of emergency EEG scenario. We have
Okay.
some resources available for that. Yeah.
Got it. But for someone who has like recovered to a full neurological baseline, then perhaps then the urgency is not as imminent as
Yeah.
in the case you just
Yeah.
described.
Yeah.
Okay,
Yes. Correct.
thank you. And the last question, I guess has to be contextualized, but in general, so many of these patients get EEG done and it's negative. So how useful is it in terms of excluding seizure activity?
Oh, okay. So obviously it's a gold standard. If somebody is having an event in front of your eyes
Yep.
and the EEG is on, if the EEG is completely normal during this episode, then you are quite confident that this is not
Yep.
epileptic in
Mm,
nature,
mm,
right? So in that sense, it's a very good test
yep.
to distinguish non-epileptic events versus
Mm,
an epileptic seizure. EEG is less useful in the interictal state. So that means you have somebody who had an event, has
yep.
recovered, has back to normal. EEG is normal. Does that uh, confidently tell you that that event was not a seizure? No.
Okay. So it's also important when we chase EEG reports to find out the relationship, temporal relationship to the activity
Yeah.
that happened.
Thank you, Dr. Rahul. We're just wondering for patients with first onset seizures, what are the basic workup that we should perform for these patients?
Okay. So for all adult patients who present with the first unprovoked seizure, then certainly they should have some form of neuroimaging. In the practical sense, if they present to the emergency room, then most of the time the emergency room will just do a CT scan of the brain, which is fine. Obviously, depending on resource availability, an MRI gives you much better resolution of the brain, but the CT is adequate to look out for the more worrying things like hemorrhage or space-occupying lesions, and those sorts of things. So certainly they should have a scan. I definitely would always stress that all these patients should have at least a glucose check,
Yep.
just to make sure it's not hypoglycemic. Then you do routine blood work, electrolytes, liver function tests. There's some suggestion of illicit substance abuse, and we want to do some toxicology.
Mm,
And then EEG, as we discussed. And investigations beyond that really depend on what the clinical scenario is.
yep.
So if there's some suggestion that the seizure may have been a first sign of an underlying CNS infection, so somebody who's febrile, has a history of headaches over the last few days, then you go on to do lumbar puncture and further investigations along those routes.
Okay, got it. Thank you. So the next question would be, when should we be starting AEDs for patients with a first onset seizure?
Yeah, so that's an interesting question. So the definition of epilepsy has changed a little bit over the years.
Okay.
Previously, you were required to have two or more unprovoked seizures before we would think about starting medication.
Yep.
There's been a little bit of a paradigm shift in the sense that if a patient presents for the first time with a seizure, but as part of your workup, you identify certain risk factors
Mm.
that indicate that this patient is now at high risk of having a subsequent event, then we do offer these patients anti-epileptic, anti-seizure medication. So an example would be somebody who's had an MCA stroke 3 months ago,
Mm.
and then presents now with the first onset of seizure.
Yep.
So you know that this patient has had a prior brain insult,
Mm.
and just by that structural abnormality that we see, he is going to be at high risk of developing subsequent seizures. So we would certainly then talk about whether they want to go on to treatment.
Okay.
Other risk factors, for example, if you see an EEG and it's highly abnormal, that may also present a point for discussion about starting medication.
Okay.
If somebody presents with a nocturnal seizure in his sleep, then obviously that's a little bit more risky, and you may want to think about offering medication to that patient. If somebody has had a major injury as a result of the seizure, and you obviously don't want to run the risk of having another injury, then sometimes we do offer medications to those patients. And of course, lastly, I personally empower the patient a little bit. So some patients are so scared or stressed after that first event that they ask you to start them on medication. So if the patient wants to start medication, then I don't say no. Of course, you have to discuss the risk benefit profile, the risk of side effects, etc., etc. So we try and make it as informed decision as possible.
Okay. Thank you
Okay,
very much, Dr.
thank
Rahul.
you. So moving on to choosing between AEDs, because there's so many different drugs available at this point, wanted to ask what are the usual medications that we can consider starting as the first line, as well as its doses.
Okay, that's a difficult question to answer. So the decision about what medication to give really revolves around several questions. One, as I mentioned earlier, is whether this patient has a particular epilepsy syndrome that you have identified. These are not very common, but if you have identified a syndrome, then there's enough data to suggest that you should be using certain drugs rather than others. So, for example, syndromes like what I mentioned, JME or Epson's epilepsy, then you would use something broad spectrum like sodium valproate, or levetiracetam, for example, and you would not use drugs like carbamazepine or phenytoin because that may worsen the epilepsy syndrome. So that's one scenario. The second and third questions are really the risk of side effects and also the cost of the drug. So unfortunately, that's a reality that cost definitely plays a significant role.
Yep.
I know in clinical practice, a lot of the more junior staff and some non-neurology specialties like using levetiracetam as a standard drug. Not that there's anything wrong with it. The advantage is that it's broad spectrum. It can be applied to almost any epilepsy syndrome. It is relatively lower in terms of side effect profiles compared to some of the older drugs that we use. So it has an advantage in those instances, but the biggest disadvantage to the patient is sometimes the cost.
Okay.
And we have found that that impacts actually on the management, because very often when they come in the ward, they get started on levetiracetam and they get discharged. But then when they have to buy the levetiracetam as an outpatient, they obviously have to pay out of pocket. And that can create a problem to the point where I have had several patients who've just not been compliant. So they stop taking medication and then have subsequent breakthrough seizures as a result. So these are important factors to keep in mind. Other common drugs that we use, sodium valproate, phenytoin, the common ones that we use. The advantage being they're very cheap.
Yep.
Disadvantage being obviously some of the older drugs have more in the way of side effects. So, for example, you need to check the liver function. There's weight gain with valproate. There's cutaneous skin reactions with phenytoin. So these drugs are not without their own problems.
Yep.
ultimately there's no specific drug that one would start. It really depends on these mix of factors that I described earlier. So it's tailored to each individual patient.
Okay.
Uh, I wouldn't recommend. I mean, in our kind of setting, it's probably better to get neurology involved before deciding on what medication to start.
Yep. But maybe you could give us an idea of the cost profile difference, let's say with something common like valproate, comparing to like, let's say Capra, how much more are patients paying?
So you're comparing between a factor of cents versus dollars.
Okay,
So it
okay.
can be a magnitude of 10 times or more per
Okay.
tablet. So if you
Yep.
extrapolate that the course of months or years, it can be quite a big difference.
Mm.
Um, you asked about dose. So obviously each drug has a different dose profile,
Yep.
a different starting dose and a different ceiling dose.
Yep.
As a general principle, I always encourage residents or colleagues to start at the lowest possible dose and
Okay.
then titrate upwards gradually.
Mm.
Um, there's no magic answer about what is the ideal dose for each
Mm.
individual drug. You really have to tailor it depending on adverse effects, side effects,
Yep.
and how good it's doing at controlling the seizures.
Okay. Maybe for like the common ones, like let's say sodium valproate, and maybe for Capra, how do you start in terms of starting goals, and how
Yeah.
fast do you up titrate in terms? Is it weeks? Is it months? Or, yeah, maybe you could take us through that.
Okay, so for example, valproate, so what I would tend to use is Epilim Chrono.
Yep.
So that's the more slow release version. The starting dose is 300 milligrams. And again, it depends on the patient profile. Normally, I would start at 300 milligrams twice a day
Okay.
and then build up following that. If I'm really concerned that the patient may develop adverse effects, somebody is frail, um, or you have the feeling that the patient is likely to complain of some adverse effects, and I may even start at 300 milligrams once a day for 3 to 5 days
Mm.
before stepping up to a twice a day regime.
Okay.
Um, for levetiracetam, it's a little bit less of an issue. So you could start at 250 milligrams twice a day with relatively no problems, and then stack that up to 500 milligrams and so on and so forth. Again, depending on response.
Okay.
We have seen some patients, for example, who have been started on 1,000 milligrams twice a day of levetiracetam. Now that's fairly high, and a lot
Yep.
of patients will develop some adverse effects.
Okay. Okay. And in terms of deciding those adequacy, and you mentioned response, so we'll be looking for any absence of breakthroughs of seizures with that prevailing dose of medicines. Is that correct?
Yeah, correct. So I mean, of course, you then obviously have to longitudinally follow up the patient, and most of the studies looking at drug efficacy, rather than looking at absence of seizures, they
Yep.
define a responder rate as a 50% reduction in the pre-treatment seizure frequency.
Okay. So the next question, it's a little bit random, but uh, so I think a lot of us usually think of seizures in terms of the GTCs that we see. That's probably
Yeah.
the seizures that we see the most. Um,
Yeah.
so I think the first question is, in terms of prevalence, is that something that is really a lot more common, or it's just that we don't pay attention and don't really pick up the former group of maybe the focal seizures? And I think the second question is that when there's a true GTC, the patient has lost consciousness, I think people generally get very scared and will respond immediately. But maybe there are patients with, let's say, ongoing focal seizures, and they may be in status for that focal seizure. So I just wanted to find out in terms of like the risk to the patient, is it about the same? And yeah, how should we be thinking about these questions?
Okay. So to answer your first question, because there are two things one talks about. So one is the type of epilepsy. So does the patient have a focal or generalized epilepsy syndrome?
Yep.
And the second is this a focal or generalized seizure? So both
Yes.
are slightly different, right?
Okay.
For practical purposes, what you're talking about is trying to define the seizure that has occurred.
Yep.
And you're right. So vast majority of the description is going to be this generalized tonic type of seizure, right? That's the most dramatic. But in almost all adults who present for the first time with seizure, almost all of them will have a focal onset to the seizure. Okay, it may be a focal onset that we cannot see, we cannot appreciate even on the MRI or EEG, we cannot appreciate it clinically, but the vast majority are focal onset. Now, what happens is during this tonic-clonic phase, what has happened is that the focal onset has now spread to both hemispheres of the brain, and that causes the tonic-clonic seizure. So, in fact, now we've changed the definitions now, so you would describe that seizure as a focal to bilateral tonic-clonic seizure. We're trying to move away from this term generalized tonic-clonic seizure because it causes this confusion that you have described.
Okay.
Yeah. Now, so that answers that about prevalence. So almost all adults will certainly be focal in onset. Yep. Then, how do they differ in clinical significance? Okay, so if you have somebody who's having bilateral tonic-clonic seizures in front of you, and that is a kind of a neurological emergency, so you need to arrest this as soon as you can. Even going to the stage of inducing anesthesia and intubating them and sending them to the ICU. And this is time sensitive. So time sensitive for several reasons. One, we know that the longer this type of seizure occurs, the higher the risk of neuronal damage. Second, and this is probably the more acute thing, is that these kind of seizures have a lot of systemic complications. So there's a lot of autonomic dysfunction due to adrenaline surges. So you will get disruptions in blood pressure and hemodynamics. You get lactic acidosis, you get rhabdomyolysis, all of which cause multi-organ problems. So that's the main reason why you need to arrest those as soon as possible. If you have somebody who's having a focal seizure in front of you, so a focal seizure, an example being somebody who's sitting there with just focal twitching of the arm, but is otherwise able to talk to you and respond, then those are far less of an urgent thing. You obviously should try to arrest it. You should medically treat them, but you may not resort. You may not need to resort to using general anesthesia and ICU type of care.
Okay.
The same would also apply for somebody with focal unaware seizures. So somebody who comes in, a little bit confused, but still can respond somewhat, and then you do an EEG and you can see that there's a epileptic discharge from the temporal lobe. So that's a focal thing. Those also you can treat with AEDs, but try and manage them on the ward rather than sending them down straight away to ICU.
Okay, thank you very much.
Moving on to the next question, it's quite a long question. We fairly frequently see breakthrough seizures, especially in the emergency department. So we're just wondering, do all breakthrough seizures need to be admitted?
No, so actually I have an arrangement with the emergency room, emergency department. So these are, if these patients have returned to normal neurological baseline, no signs of any major injury, and there is a carer at home who can supervise the patient, then the patient can be discharged.
Okay.
Failing which, then sometimes we sort of hold them in the EDTU for 24 hours just for observation, and then they go home from there with an early appointment to see me in the clinic.
Okay.
Then the next question is, do we always need repeat brain imaging, or only if, let's say, the seizure is unlike their usual?
Yeah, okay. So no, we don't always need to repeat the brain imaging. The scenarios where I would certainly do another scan is one, like you described, the seizure pattern is different from the usual one. Number two, the patient has not returned to his or her neurological baseline. Three, if there are signs of head injury that may have occurred during the seizure. Four is, for example, if somebody is on warfarin and had an unwitnessed seizure, then I would have a lower threshold to scan those patients just to exclude something like a subdural or a traumatic injury.
Okay.
Okay, thank you. Next is, there are some AEDs that we do drug levels for. When do we need to check, and for which drugs?
Okay, so I encourage everybody who is looking after patients who present with breakthrough seizures to check drug levels. So those are useful for several reasons. It then can give the treating neurologist a rough idea about whether there is space to, adjust the dose. Um, Also, we have found this time and time again that patients say that they are compliant, and then you measure a drug level and it's undetectable, whereas it has been detectable in the past. So then you can actually say, look, this time your drug levels were undetectable. Yeah. The drug levels that we measure routinely in our lab are phenytoin, carbamazepine, sodium valproate, and phenobarbital. So if you have a patient who's on any of these drugs, then I think it's worth doing a level.
Okay, just a bit of a practical question, because sometimes, let's say, the emergency and the on-call, let's say, doesn't do the level, then the patient was sort of served the medicine, maybe a couple of doses, and then you are seeing like the next morning. In that case, is there any point in doing the level still? And yeah, how do we deal with such a situation?
No, so I think in those kind of scenarios, it becomes more difficult to interpret,
Okay.
especially if you're trying to determine compliance. So that's then, of course, not useful.
Okay.
Which is why I think it's very good practice to check a level when they come in. And the reason is, if it's undetectable when they arrive, you ward them and they've had a couple of doses, and you repeat a level just prior to discharge, and the level is now in the detectable range, then you have answered that question.
Okay, and how long after that do you repeat the level? Is it like 1 to 2 days, or how do you decide?
Yeah, so 1 to 2 days is fine, or just before discharge, whenever they're going home. Yeah.
Okay, thank you.
Just one point to note, I have seen a couple of times now where it's been labeled as non-compliant because the drug levels are low. It becomes very difficult to label somebody as non-compliant just because the drug levels are low. It just maybe the dose was inadequate.
Yep.
So just low drug levels is not enough to say that they are non-compliant.
Okay, so it's more undetectable, then you would be more confident of saying that they are compliant.
And even in the undetectable one, that only holds true if you have had detectable levels before.
I see.
On that same dose.
Yeah, because this has happened. I remember very clearly one patient who every time came in had undetectable levels. I mean, he came in with status,
Yep.
And then he had IV phenytoin, I think. And then when he was transferred up to the ward, we converted it to oral, and then his levels became undetectable again. So that is because some patients metabolize the drug differently through the gastrointestinal system.
Okay, thank you.
Okay. The next question is, when we assess for breakthrough seizures, on top of looking for the usual triggers, we also see if the pattern of the seizure is the same as the usual. Is there anything else that we need to assess for?
Yeah, so I think A, compliance, B, the potential triggers, commonly being sleep deprivation, recurrent illness, those kind of things, very common.
Okay.
And also adverse effects.
Okay. Very frequently when our patients do come in for breakthrough seizures, we tend to increase the AEDs dosing for a short while before returning back to normal. Just wondering, is there any guide on how to increase and for how long?
Okay, so generally I try and discourage manipulation of anti-seizure drugs, in a very up and down fashion, because that can create some erratic changes in the level. So really, the first question you need to ask yourself is really, do you need to dose adjust? Right?
Yep.
So obviously, in somebody who's not compliant or may have forgotten a few doses here and there, then I may not necessarily adjust the dose. If there's a clear trigger for this particular seizure, again, you may not want to adjust the dose. And if and you'll be surprised, a lot of patients that I see in the clinic actually don't like to increase the dose because A, they are worried about the side effect profile. So a lot of patients that I see in the clinic would say, look, can we just monitor the situation for a bit longer? Okay. But out of these circumstances, say if you've decided, okay, this patient should have a dose increase, then I would increase and keep it at that higher dose rather than increase for a while and then reduce.
I
Now,
see.
if you're talking about an acute intercurrent illness that has triggered this seizure,
Yep.
then you may want to use a bridge. So I like clobazam. A
Okay.
lot of us use clobazam. So that's a useful bridge to tide them over that acute period. And
I see.
clobazam is specifically designed for this kind of use, intermittent use.
Okay. So instead of, let's say, bumping up the valproate or the Keppra, then you would just use the clobazam as something to tide maybe for like a week or so, and then
Yeah,
once they are better, then they just stop.
correct.
Okay. How normally do you go about dosing the clobazam?
Okay, so that's also a little bit of a gut feel.
Sure. Mm,
For the very, for example, frail patients,
mm,
very thin patients, I may not want to. Our standard dose is 10 milligrams twice a day.
yeah.
But I've had a few patients who become very drowsy on that dose, so then I
Mm,
halve it to 5 milligrams twice a day.
okay. And let's say patients like, some of these patients may have like recurrent UTIs or recurrent infections and they keep having breakthroughs on these. Do you ever
Mm.
like give it as a prophylactic, like, sick day kind of thing, upfront before they even break through, or not really?
Yeah. So I use clobazam for those circumstances. I also use clobazam for patients, for example, who have more seizures during the menstrual cycle.
Okay. Mm,
So tell them to just take a week of clobazam during their cycle.
okay.
And all of this is designed to try to avoid having to increase the daily dose if you can.
Yeah, understand. Okay, thank you. That's really helpful. Okay, just a quick bit on status epilepticus. Maybe you could just help us revise how this is defined and whether there's been any changes in recent times.
Yeah, I mean, I think the big change over the years is actually the duration. So now it's generally accepted that an unremitting seizure that goes on for more than 5 minutes should
Yep,
be defined as this.
yep,
And obviously, two seizures happening back to back with no neurological or poor neurological recovery between the two events would also qualify as fatal.
okay. And when one calls it a status, normally, what are the agents that you reach for in the immediate setting?
Okay, so the first drug that we would use is a benzodiazepine.
Okay.
Um,
Mm,
and you have several choices. During my time, lorazepam was only available at certain wards, ICU, Ward 57 emergency room.
mm,
All other wards had midazolam.
yep. Mm,
Now I think it may be a bit different. So you can choose between diazepam, midazolam, lorazepam. Between the benzodiazepines, for pharmacokinetic reasons, lorazepam has
mm,
been shown to be probably the most effective.
okay. Mm,
um, it has a longer half-life, so there's a longer duration of action.
mm,
It's less lipophilic, so it remains in the vascular space for longer, so
yep.
efficacy is better.
Yep.
But really, the take-home message to emphasize to everybody is that it's more important than what drug you use. It's the timely intervention,
Mm,
and this is something that sometimes we forget because a lot of these things happen in the middle of the night.
yep.
You
Mm,
happen to call, somebody has a seizure, then it stops spontaneously, and then you carry on with the rest of your call.
yep.
Um, and then the patient has never regained consciousness
Mm,
and never come back to normal. And then
yep.
has another
Mm,
seizure maybe 3 hours later that felt aboard.
yep.
And so then we may miss the fact that this guy has, or this patient has probably been in status for an extended period of time.
Mm, okay.
So it's timely intervention. The other scenario is, of course, sometimes we wait and see whether the seizure is going to stop on its own before we give something.
Mm,
And so again, we should probably move away from that. If the seizure is still happening in front of you, then really you should intervene with whatever is available, whether it's midazolam or diazepam, whatever.
okay.
Then your second phase of your treatment, if seizures are not stopping, is then you would top up or go on to anticonvulsant drug intravenously. So you
Mm,
can choose between phenytoin, valproate, and levetiracetam.
yep.
Um, the studies over the last 5 or 10 years have shown that last time we used to use only phenytoin,
Okay.
but now it appears that valproate is probably equally effective, if not slightly more effective than phenytoin, and it
Mm,
has the added advantage that it doesn't have any major hemodynamic problems.
okay.
So I generally encourage people now to try using valproate first instead
Okay.
of penetrane.
Mm.
You could also use levetiracetam that is available intravenously. So you could choose either levetiracetam or valproate.
Okay.
And it's not stopping them moving on quickly to the next one.
Sure. So practically speaking, I guess, because normally you would give a sort of like a bolus and then subsequently an infusion, is that correct? And so so let's say you've given your benzos, and let's say the patient's still having a seizure. Practically, what are you giving at the bedside? And then when do you start the infusion? Is it like in the ICU? So maybe just take us through a practical step-by-step thing that you would do. Let's say you are seeing this patient on call. Although, yeah.
Yeah. Okay. So you're allowed two tries of a benzodiazepine.
Okay.
If that fails, you got to move quickly on to an anti-epileptic. So, for example, you load the patient with sodium valproate.
Yep.
So, sodium valproate we use about 20 milligrams per kilo.
Mm.
You would give that in as a pretty quick infusion.
Yep.
Or you can use levetiracetam. So some centers even use high doses such as 3,000 milligrams, some
Mm.
even more.
Yep.
Um, and if that fails and you need to move on to the third stage, then you are trying to induce anesthesia or
Okay.
sedate the brain
Mm.
in order to try and control the seizures. Now that it's tricky to do on the ward unless you have secured the airway,
Okay.
right?
Mm.
So usually you would need to intubate the patient, and then you can start your infusion, and that really depends on what your drug of choice is. So you can start a midazolam infusion, you can start a propofol infusion, um, and if those fail, then we move on to a barbiturate infusion. But probably on the ward, you want to use either midazolam or propofol.
Okay. Thank you.
Okay, and this is our last question. So, in terms of in the clinic setting, when we're following up with patients with epilepsy, what are the things we should be looking out for?
Okay. So again, you want to have an idea of what the seizure frequency has been like since you last saw the patient.
Mm.
And then you want to find out whether the patient has been compliant with medication, whether he has developed or is complaining of any adverse effects to the medication. If there have been intermittent or intercurrent seizures from the last time you saw him, then usually it's a good practice to try and get a feel about what happened during each seizure, and to see whether these seizures had a particular trigger so that you don't really need to adjust the medication, or again, these were unprovoked and therefore you may want to think about adjusting the dose of your medication.
Okay.
It is usually good practice if you're seeing a female patient of childbearing potential to ask them at each clinic visit about whether they have any plans for pregnancy.
Yep.
And you have to advise the patient regarding the potential teratogenic effects of the anti-seizure medication.
Mm.
And if they are female patients of childbearing potential, then I usually encourage them all to start folic acid,
Okay.
which tries to help in some way to mitigate this teratogenic risk. So now, most practice guidelines would say that all female patients of childbearing potential should be started on folic acid, whether or not they have plans to become pregnant.
Is there any
Because
particular AED of choice that's favorable for women who are planning to get pregnant?
okay, so there are none that actually is favorable, but I would say the most unfavorable one would be sodium valproate.
Okay. Okay.
So sodium valproate carries with it the highest risk of teratogenic effect.
Mm.
And there are also now studies to show that beyond that, it seems to affect the IQ of the children.
Okay.
And there seems to be a higher incidence of things like autism in children born of mothers who are taking sodium valproate. So really, we try and avoid sodium valproate, or if they were on valproate in their childhood years, then I try and switch them to an alternative drug when they're adult.
Okay. Do you do any like routine blood tests and follow up, maybe for the common medicines, like let's say valproate or capra or phenytoin, to look for side
Yeah,
effects? Mm.
Yeah, so especially for these older drugs, you want to check things like the full blood count, your liver function, because
Mhm.
valproate, for example, can be
Mm.
associated with thrombocytopenia.
Yep.
Some of these older drugs can cause some degree of transaminitis.
Mm.
Um, Carbamazepine can cause hyponatremia, so you want to check the renal panel and somebody with carbamazepine. There's no particular guidelines about how often you should be monitoring the blood test. So I just share
Okay.
with you what I do. So
Mm.
if I start somebody on this drug, then I usually want to do repeat blood test probably about the 6 to 8 week time point.
Okay.
So that if there are any abnormalities, you can try and catch them early.
Mm.
And then for patients who are already established on drugs for a few years, for example, and every time you check it's been stable, then I do it maybe once annually or once every 2 years.
Okay. Thank you.
If let's say one of these patients have been following up for a while, there's no breakthrough seizures, at which point do we consider down titrating the AEDs?
Okay. So again, that depends on that earlier point about whether you're able to risk stratify the patient. So, for example, if somebody has a diagnosis of epilepsy and his scan is normal, there's no structural brain abnormality, and they have remained seizure free for 2 years, then you may offer them a gradual dose reduction if they're keen to do so. Of course, when you reduce the dose with an aim to stop, then you also have to apprise the patient that there is a risk of recurrent
Yep.
seizure may come back.
Mm.
So again, it really is specific to the patient. So again, I empower the patients to try and make a decision for themselves. Some, for personal circumstances or social circumstances, would prefer to continue on medication, especially if they're not getting any adverse effects.
Mm.
I have others who want to stop medication even 3 months after starting medication. So it really varies from patient
Yep.
to patient.
Okay.
Now, if somebody has an abnormal scan, for example, if somebody has a cold stroke, for example, then I would really be a bit more hesitant in trying to withdraw them from medication because their recurrence risk is going to be very high.
Okay. Okay. Thanks a lot, Dr. Rahul.
Thank you.
So I think we've covered the questions that we wanted to ask. Thanks so much for the very fruitful and insightful discussion. Maybe for the listeners, do you have any key take-home points that you want them to remember from this session?
I mean, I think from kind of the junior perspective,
Mm.
the kind of patients that you're most likely going to be seeing are those who present with the breakthrough seizure.
Yep.
So I would encourage everyone to, when you clerk these patients, to try and identify whether there are specific triggers
Mm.
uh, to the breakthrough seizure compliance. Always remember to check drug levels if they can be checked.
Yep.
Yeah. But most importantly is actually the patients who come in with status, because the residents are going to be the first line to see them.
Yep.
And invariably, these things always, like you say, happen in the middle of the night.
Mm.
So one is timely intervention. So if somebody is really having a convulsive seizure, you really need to arrest it. And it's not the case of giving medication, going away and coming back a little bit later to see whether
Mm.
things have stopped. You really need to be with the patient until you've sorted it out. Okay.
Yep.
The other scenario is if you're called to see somebody who's had a breakthrough seizure, but the seizure has aborted spontaneously, do remember to come back and check on that patient
Mm.
a little while later, just to make sure that they are slowly coming out of it and going back into baseline neurological status.
Okay. Thank you very much, Dr. Rahul.
Okay, take care.